Welcome, everyone. My name is Dr. Calvert Tisdale, and I am a postdoctoral research fellow at the National Drug and Alcohol Research Centre, and I will be chairing today's very exciting webinar. I'd just like to start by saying thank you for joining the webinar series and to give a warm welcome to our audience, which is made up of many varied perspectives, including researchers, health professionals, various stakeholders, members of community, and people with living and lived experience as well. Before we start with the webinar, I would also like to begin by acknowledging the Bidjigal and Gadigal people as the traditional custodians of the land from which I am joining the meeting today. And I would also like to acknowledge the traditional owners of country throughout Australia, noting that our speakers, panelists, and audience are all joining from many different locations across Australia, if not internationally, and also pay my respects to the elders past and present, extending that to any First Nations people that may be present today. So for today's webinar, I have the pleasure of introducing Dr. Timothy Piatkowski, who is a globally recognized leader in harm reduction research focused on image and performing enhancing drugs, or IPEDs. He was recently awarded a prestigious NHMRC Investigator Fellowship to examine how both individual behavior and systemic factors, including stigma and healthcare access, shape the risk profiles of steroid consumers. Dr. Piatkowski brings a distinctive combination of lived experience and academic expertise to his work, which includes a research program that triangulates perspectives from IPED consumers and health professionals to address pressing gaps in policy and service delivery. This also includes the design and implementation of the world's first steroid drug checking trial and the founding of Steroid QNECT, which we have put in the resources that you will see in the chat today. Australia's only Steroid QNECT is Australia's only peer-led steroid education initiative, and it now informs national harm reduction strategies. So Dr. Piatkowski has received multiple accolades, including the AVIL Peer Researcher Recognition Award, the APSAD Kip Kipri Early Career Researcher Award last year, and all of this is to say what an outstanding researcher he is. So following that amazing presentation, we will also be joined for the panel discussion by Associate Professor Monica Barrett and a PhD candidate who works alongside the project, Ian Miller. So Monica Barrett probably needs no introduction, but she is an associate professor at the Criminology and Justice Studies School at RMIT, a university in Melbourne, and also the lead researcher for the Loop Australia, which is a charity providing drug checking services at festivals and in community. Monica has an internationally recognized research profile over her 20-year career, including and focusing on emerging drug trends, as well as drug checking or testing drugs for harm reduction. Ian Miller, as I mentioned briefly, is a current PhD candidate at Southern Cross University and is currently working as a steroid chemist alongside the chemical analysis team on the project that we will be seeing today from Tim. As a reminder, we're going to have time for questions at the end, so please put them in the Q&A function that you see at the bottom. I may not be able to get to all the questions, but I'll do my best to do so. And of course, you can always reach out if your question is not answered to our communications email. So that's probably enough for me. I will now invite Tim to turn on his camera. And I will get you to do a presentation. Thank you so much, Tim.
Thanks, Calvert. Good afternoon, everyone. Thanks for having me. Really excited to be here and be able to present some of the work from our steroid checking trial, which took place last year. Just to preface this, the trial operated in 3 waves, which I'll get to shortly, with the focus of today being the wave 2 of that trial. Just before I continue, I want to acknowledge the traditional custodians of the land on which we're meeting and pay my respect to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people on Turrbal Yagara country today. Want to acknowledge my role in QuiVAA and QuiVAA's long legacy of over 40 years of harm reduction through lived living experience. It's really stand on the shoulders of giants in being able to present this work as well as, I guess, do the work in community that I do, and very, very grateful for that. In terms of this trial, this wasn't, a one-person job at all. This was actually a huge team of partners with, only some of the, or most of the organizations and partners represented here, and one of them on the panel. Well, sorry, two of them on the panel. But just acknowledging all the respective organizations, institutions, and people involved. So just to reorient us in terms of, I guess, knowledge, so that everyone's on the same page. I guess when we talk about steroids, we think about maybe needles that people are sticking into each other or tablets that they're taking. So when we talk about steroids, we're actually talking about image and performance enhancing drugs as an overarching category. And anabolic-androgenic steroids are one of the types of drugs that fit within that category. These are a lot of the time medical substances, and they're used for medical purposes, and I think we forget that sometimes. The only difference is, I guess, that predominantly the community that I work with and advocate for uses these products non-medically or off-label. And so when we talk about steroids, we're talking about injectable compounds, so the oils over here, so things like testosterone, trenbolone, drostanolone. We're also talking about oral tablets, so things like methyltest, dianabol, halotest, and turinabol, etc. And these are generally taken orally or can be suspended in a liquid, which doesn't taste very good. And then there's other image and performance enhancing drugs. So things like human growth hormone, which is injected subcutaneously, things like insulin, again, subcutaneously or intramuscularly, and designer steroids, like wonderful Superdrol, which is really, really good for your liver. And so I guess just sharing this with you to say this is a fantastically large category of drugs that we're talking about. I guess in the literature, we've got over 32 different anabolic steroids which have been recorded. And so, it's a little bit different when we talk about drug harms as opposed to, I guess, when we talk about things like perhaps opioids or amphetamines. So just want to reorient us to that. In terms of the illicit steroid market, Australia is a world leader in a number of things for both good and bad reasons. But particularly in terms of illicit steroids, I just want to share an interesting number with you. EMCCDA data suggests that over the last decade, there's been an increase of about 750% in terms of the weight of steroids seized globally. For Australia, just drawing your attention to this number down here, during that same period, the weight of steroids that we seized was almost 1,400%. So very much leading the world in terms of the increase. We seize over or approximately half a ton a year. The other thing that we do really well here is that we arrest and punish people who use steroids. And over that same period, we've had an increase of 267% in our arrest rates. So we're arresting well over 1,000 people a year. Most of these arrests are actually the end user or the person rather than supplier or distributor or trafficker, if you want to use that type of language, because they account for 82% of our national arrests. In terms of I guess globally, we in Australia have poor mechanisms for detecting prevalence and I guess monitoring steroid use as it occurs. But we know that about 3.3% of people globally use them, um, and that they're uh, associated with substantial physical and psychosocial risks. So things like hypertension, reproductive issues, if you're injecting bloodborne viruses, bacterial infections, and then lots of psychosocial issues like depression, suicidal ideation. If you're using trenbolone, perhaps verbal aggression, so on and so forth. And just some quotes from participants here in terms of, you know, demonstrating that lived living experience of the uptick in social media, accessibility, influence, and just general level of, I guess, cultural awareness around steroids, and what it does for people. Beautiful picture here. I was going to put a video, but I thought maybe some of us had eaten not long ago. All those risks I spoke about are somewhat manageable in terms of harm reduction strategies and in terms of dosing at clinically prescribed levels. What we can't control for, or what we struggle to actually control for, is the booming unregulated market that I spoke about earlier. And so the fact that we're using mislabeled, counterfeit, or misidentified steroids actually causes substantial harm to community. And you can see here, flesh-eating bacteria and abscess strain has really eaten away a large portion of someone's gluteus maximus. And so when dealing with unregulated markets around illicit drugs, we know that drug checking is a fantastic innovation. Its implementation is very, very much known around the world, I think in 51 different countries from memory. Positive outcomes in terms of receptibility, acceptance, and willingness. And certainly we've recorded the same thing for people who use steroids, if you go to the QR code there. And so in 2023, when Queensland announced its intention to have a drug checking service, and QuIVAA and the Loop Australia formed Checkpoint in early 2024, we noted that there wasn't provisions or equitable provisions for people who use steroids. And so in the interest of supporting and advocating for an underserved community, we thought, why not have a go? And I guess the interesting part about drug checking in general is that lots of people do it, and there's plenty of services around. In terms of steroid checking, there really isn't much. And so it's quite absent on a global scale because of logistical and technical challenges, unique training and skill set for staff. You need off-site testing facilities, validated methods and libraries, need reference standards, which are the materials used to test against purity, and qualified staff to be able to do all of this. Not to mention, as we've seen, a level of community embeddedness and ties where you're able to ask people in community to bring in samples to trust you to be able to deliver on promises, and then to see that come to fruition and be able to continue to advocate and build on that is, I think, quite unique. I'll note now, though, that in Switzerland, some colleagues of mine also doing drug checking, so steroid checking, and in Barcelona, there are also some colleagues doing some hormone analysis and testing that I know of. So we launched the world first steroid checking trial in 2024. It was, I guess, well received by community, well received by some national media. You can see it, that QR code there if you want to look at the piece ABC did on it. You can see some of my mates here. Incidentally, Sarah is currently the strongest woman in the world, I believe, with a 315 kilo squat. So when we launched the trial, we launched it in three waves. So wave one was between April and June 2024, wave two, June to August 2024, and then wave three was August to October 2024. So we'll be focusing on, I've spoken previously about this on the left-hand side. We'll be focusing in on the middle here about what happened between June and August and how that fits in. And so each wave had two phases. In phase one of each wave, we asked community to bring in their samples. We put a call out with some slick marketing and asked them please to bring in their steroids so that we could ship them off to the Griffith University lab, perform chemical analysis and work out our methods for qualitative, so whether the steroid was present, or quantitative, what the purity level is of those oils, tablets, and powders. So we used, we did try FTIR, we used a Radiant ASAP for qualitative, so presence testing. We used LCMS for the purity, used an Orbitrap 360. And so we analyzed that, we built up our reference library, we continued to ask community to bring these vials and tablets in for us. And then we published those results in each wave through posters and social media. The second phase of that, and you can see my mate Adam here, who's an independent researcher from Thailand, works with myself and Vigorous Steve. In this second phase, we did some semi-structured interviews. And so that was at wave one and at wave two. And so interviewed people about what their perceptions were regarding the results that they saw, asked them about risk, reward, and then analyze that data thematically using the health belief model as well as inductive coding. And just reflecting on wave one here, so the April to June, which was the first one, you can see the actual test results on the left-hand side. The work in addiction, which has been published already on wave one, and then the work in drug and alcohol review, which has been published out of the community notices that we developed from wave one. In terms of wave one, we had approximately 31 samples come through. We could only test 23. We did presence testing on the 23, but we only did purity testing on one while we were trying to scale up our methods, get something out to community and sort of try and balance everything that was going on in a timely fashion. And so when we interviewed the 25 initial participants, there was a lot of feedback around the need for purity, the need for brand recognition, and I'll come back to this, and the need for a cleaner, clearer presentation of the results to be able to assist them in making well-informed health decisions. There's some commentary around a few other limitations that we have. And so we set aside, I guess, a mission for ourselves to really overcome as many of these limitations as we could. And so this is a nice little figure representation of the explanatory sequential approach that we took in wave two, in that all that learning from wave one and in those phases we took and we integrated here. If you look at the middle of this model, we actually reanalyzed all the samples from wave one. We brought in additional samples from community for wave 2, and then we analysed those, disseminated them, and then followed up with 15 of our 25 participants, so 40 interactions in total. And the block of time for wave 2 is June to August, but the follow-up did take a little while, petering out into November. And so in terms of what wave 2 looks like, there's the large QR code will take you to the wave 2 report. The smaller QR code takes you to some extended harm reduction advice, and I'll come back to that in a moment. We were able to analyze 46 of the samples, but now we have this beautiful looking report and table where we had the expected compound concentration. We reported the underground brand, and this is very important. When it comes to unregulated steroid markets in Australia, all over the world, we have underground labs or UGLs that are branded and produce, manufacture and distribute steroids. So, for example, Alpha Farm, Platinum Anabolics, QuIVAA, so on and so forth, Tim Labs, whatever. You get the gist. And so, as opposed to, I guess, other unregulated drug markets, all we know about steroid markets in Queensland and in Australia is that if I have a brand here in Queensland, it's quite likely that Calvert might see the same brand down in New South Wales, or Monica might see the same brand down in Victoria. And so it's quite a known market, and there's some inferences that we're able to make. And I want you to remember that point because I'm going to come back to it. We've got the detected compound here, so whether it was present or not, whether that's a match for concentration as well. And so finally, we really were able to crack this purity issue that we had in the first wave, and that was really, really important. So if the compound was detected within 5% of the purity suggested, so for example, let's pick an easier one. This was meant to be trenbolone and anthate from some Russian brand lab at 200 milligrams a mil. It matched. That's what was detected, but it was significantly underdosed. So about a third of what should have been in there. In terms of the core findings from the analysis, although we had 58 samples submitted, we analysed 46 qualitatively and 36 quantitatively. We had 9 presence issues out of those 46, and we had 15 purity issues out of the 36. We had a number of oral compounds, injectable compounds, and raw powders. So coming back to the raw powders, these are the manufacturing materials. There's plenty of guides that you can find online, plenty of guides on YouTube that will tell you how to convert this material into a viable source of androgens. So it's very interesting that we got a few of these in as well, because some other inferences that you can make from that. This is what some of the compounds look like. So tablets in a little bottle, oils, you should probably be used to seeing by now. When I released the report, we also did a little bit of extended harm reduction. And you can see this here, as I mentioned earlier. You can look through it in your own time, but I wanted to highlight, I guess, my favorite part, because I guess that's what you get to do when you present. This was something I really, really enjoyed writing and really enjoyed collaborating with the team on. Because of the purity level data, we were able to give people a usage strategy alignment formula. So in a worked example, Tim wanted to use 400 milligrams of drostanolone and anthate a week, but he had an overdose sample. And so he thought his sample contained 200 milligrams, but it was overdose. with a detected concentration of 257 milligrams. And so he'd typically inject 2 mils per dose, but we have an adjustment here. And so with this usage formula, we actually were able to give people some really useful advice in terms of how to adjust their dosage in terms of their expectations around their steroids. And there's another worked example here, which is obviously vice versa, is pushing the dosage up because it was underdosed. And I thought that was a very innovative bit of harm reduction that I quite liked. So in terms of the wave two, there were 40 interview interactions conducted with 25 participants. They were about 35 years old. In the follow-up, we had 11 men and 4 women, slightly older. Interviews went for about an hour. Everyone was currently using steroids, and most of them used between 1 and 2 different compounds. So testosterone and trenbolone, testosterone and something else. Most of them got them from community networks or a mixed source of prescription and unregulated product. In terms of sharing some of the core interview findings, so I'm going to share some quotes and a bit of interpretation around that. Participants in the follow-up really felt that the steroid testing was a fantastic tool for informed decision making, especially in that enhanced capacity that we now had it in wave 2. So they welcomed those improvements to testing accuracy. They said, I think the work that's being done is great. So much misinformation out there. When you get data like that, it's a great tool to show people what they're taking. Also provided a more balanced view of the unregulated market. So it reassured people that not everything's fake or harmful, but to have a level of caution around what they were doing. But Ben suggested that it was nice to see that there's some efficacy on the streets and people aren't just taking advantage. Coming back to that branding component, the branding was really seen as a cue to action for people in community. And because of that introduction of branding, because of that ability to enhance health decision making, it gave people an opportunity to assess product reliability. And so it directly influenced their purchasing choices. For example, Oliver said, I can see the brands, it's like probably going to stay away from that one. I see that others are good, the concentration matches, I'm getting what I bought, I'll steer towards those. And so because this was grouped in aggregate data, as I said, and we were just showing people all of the testing results, this wasn't individual drug checking per se, they were able to, because of the branding, make some inferences around their decisions. And so even though people didn't necessarily take in a steroid sample, they could look at the report and make a better informed health choice, or so they felt, about what they were doing, what they were purchasing, and how they were going about their usage strategy. And so the branding data supported this community level decision making and built collective knowledge, or was thought to build collective knowledge over time. So Brock said, from a macro level, if we have enough substances, we can make better decisions. But we also need results on this bottle. And if you can tell me what's in that one, I can make the best call. So drawing attention to the fact that, yes, this is good, this is exciting. However, we really, really need individualized results as well. And so in terms of navigating usage and health, testing was a fantastic objective marker, helped people understand what was going on for them, but not everyone has the ability to apply that information. And so without corresponding education, the objective data alone doesn't necessarily, or wasn't perceived to lead to safer outcomes necessarily. For example, Alexander said that information is great, but the power comes from understanding how to apply it. And if someone doesn't know what to do with it, the problem's essentially still there. And so really draws our attention to the idea that we have this fantastic tool that enhances decision making among, so pro-health decision making among a particular group. And what we don't have for that group is, number one, ability to give individual data, and number two, ability to translate that data into an actual strategy for them. And so those were two other gaps that we needed to look at filling. And I'll come back to my previous point in a moment. Want to spruik and share, I guess, that wave 3 of this data was released, and you can find it at the QR code here. It was released in February this year, actually. And in total, we had over 100 samples tested. But want to draw your attention to the fact that presence-wise, over a quarter of those samples had a completely different steroid in there, but over half of them were actually underdosed. So significantly different expectation alignment. We also did a bit of a survey around people who'd seen these results, who were using steroids, and what, I guess, as a health literacy pilot intervention, what those results did at a broader scale. And that's currently being analysed and written up into manuscripts. So coming back to wave 2 and the implications of that, before I actually talk about what's on the slides, what I want to hammer home, I guess, is that for every other drug checking service and component, we did have a health intervention that was delivered. And so people got individual results and people got a health intervention. We didn't have that for steroids, so we actually had to design that from scratch. But we also didn't feel that that was necessarily enough. And so what we actually have also implemented this year, as Calvert indicated, is the Steroid Connect program. And you can find the number here. You press 2 for steroids. Now, our amazing steroid peer educator, Sonia, who's an ex-bodybuilder, provides confidential guidance, advice, harm reduction through a phone line, as well as through an online forum, as well as in person at needle syringe programs. We also team together to provide training, to do advocacy for people who might experience stigma at various healthcare provision sites, as well as just generally support the community through resource production. But you can find the details for Steroid Connect here, which is a sub-program of Peer Connect, which is our ODTP program. And so I guess in 2025, essentially, there is an implementation and translation component where we are attempting to look at what the health conversation approach towards people who use steroids looks like when we give them individual results, and what that health conversation translation component actually does for their harm reduction and health decision making. So trying to fill that gap. But I would encourage anyone around Australia or anyone around the world that this is and has been incredibly inequitable for a long time, in that we don't have drug checking as it stands for steroids, but we have it for every other drug. I just want to draw parallels between that and the other harm reduction initiatives and programs that we have. We often ignore people who use steroids, don't serve them with public health frameworks, or acknowledge them in interventions or in the work that we do. And I guess what this work represents is not just the idea of testing steroids and providing a health conversation that's co-designed with community or any other program. What it represents is a critical stand that I'm hoping other people will follow in giving, I guess, my community, my peers, my friends, equitable representation and acknowledgement, and looking after their health, and enhancing their well-being and social outcomes. One other thing I want to sprig today, and we officially launched this yesterday, is our harm reduction booklet resource for steroids and other image and performance enhancing drugs. You can find it the QR code there. It's freely available. It's supported by Queensland Mental Health Commission, who fund this program of work, and it was co-designed with community clinicians, peer educators, researchers, and really contains a whole body of interesting knowledge that works for people in community, as well as harm reduction workers, healthcare providers, healthcare workers alike. It's really wonderful, comprehensive resource that we're really proud to present and disseminate. And so I think wrapping up there, just want to say thank you for your time. Thank you for your attention. If you want to contact me, my email's there, as well as various social media handles, where I post a lot of this work and try and get it out there. Probably as well as LinkedIn, which I forgot. Oops. I think we will hand over to Calvert and Monica and Ian, perhaps. But happy to answer any
Fantastic.
questions.
Thank you so much, Tim, for that presentation. It just really comes across how deeply you understand not just the use of steroids, but the people and community who are involved and impacted by it. And most importantly, what research is needed and what strategies are needed beyond the impacts. So I can see we've received quite a few questions from the Q&A, but before I answer them, I'll invite Monica Barrett and Ian Miller to please turn on their cameras. And what I might do, given Monica, your expertise in the area and involvement in the various projects, your immediate reflections after hearing Tim's presentation.
Thanks, Calvert, and thank you, Tim. It was an incredible, it's an incredible body of work that you've led, and it's been exciting to have a small role in it. I just wanted to make a parallel, I guess, given the audience that we're in here. When I was hearing you speaking about the uh, providing the brand names in the second wave and how that affected people's decisions when they were looking at the reports, it just sort of made me think, if we go back a couple of decades when MDMA was very much in pill form and it was sort of known as ecstasy and it was very much branded, that was sort of, I guess, the genesis of pill testing as it was known back then. It made sense because the pills were branded, so people could spread that information around and say, I've got this one, it looks like this. It over there, it had this in it, or it didn't have that, etc. And so that was how a lot of that information had additional currency. Of course, what would then happen is there would be copycat batches. So I just had a question for you around that. Like, is that a thing that happens in the steroid world, which seems to have quite a different, to be able to have like bottles with vials with like, this is exactly what's in it and this is the dosage. Just wondered how that looked and how this might have affected that.
Thanks, Mom. 100%. And we got a disclaimer on there. I think you remember that we considered this. I think Cam and I sat there and thought about this for a little while because we thought, it's so easy to go to Alibaba, print some holographic labels and, recreate, Tim Labs, crimp the tops, and throw it together and sell it. So if we fully acknowledge, I guess, that there's counterfeits out there, and it does happen in the same way, I guess, a brand could perform really well. Could be a counterfeit of that brand that doesn't perform so well. Could also be that, after a month or two, the batch changes.
Different batch.
Yeah.
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 Same brand, different batch for sure. Yeah. I had a second thing to just mention, and I think we've spoken about this before, but you had a one slide there where you mentioned how many males and how many females participated. And given that one of the substances tested is testosterone, I wondered whether there's been any partnerships yet or any plans to partner with transgender community who might be using gender affirming testosterone or obviously feminizing hormones, and whether or not that group, because certainly my experience at Blue Light, where we have sort of a group of folks there with DIY gender affirming hormonal treatments that they're getting through the same sources, I assume, as your folks. But have you done any of that work yet?
No, great point. We haven't interviewed or documented, I guess, those experiences yet, but it's, I guess, something we've spoken about and
Yeah.
is on the cards. I think there may have been this year some people coming through the service specifically providing hormones for this reason. But I think we definitely need to do more in that space. I know our mates at Kykeon Analytics do a lot of estrogen testing and testosterone. I think similarly, given the political climate and all those types of things, DIY testosterone and estrogen is going to pop up more and more, and so this is really important.
Yeah, thanks.
Thanks for those amazing questions, Monica. Ian, given you actually play quite a specialized role in this project, it'd be great to hear more about your perspectives, and maybe you could offer some reflections or questions on Tim's presentation as well.
Yeah, thanks, Calvert. I've got to just disclose that I've come onto this project a little bit later. I've actually taken on from one of our former research chemists, which was Madeline Harding, sorry. But yes, it's been fantastic to be part of this project and just to see the amount of work that goes on, not just like in the lab where we're actually doing the analysis, but the steps that go in to actually allow this project to take place. So there's a lot of work from like your Tims and your Monicas, the people that allow us to be able to actually do this analysis. Because I'm just like you, I find this fascinating, like this work, and it's exciting to see what we're actually finding. Again, it might be nice to say that it's started off as a like relatively small project, but with each wave that is getting published, we're getting more and more interest from the community, both in I guess Southeast Queensland, so your Brisbane and Gold Coast alike.
Fantastic. Tim, did you want to add anything to that? Otherwise, following those great reflections, maybe we'll head over to the Q&A section. I can see there's quite a few questions in there already. So I might start with Cherry Yates. Firstly, wants to know where you can get the resources that you mentioned, but asks a great question surrounding the desire of people who use steroids to access health services that can enable them to use steroids in a safer way. So, for example, blood testing, and they aren't able to access that. So what are your thoughts around health service access and how to improve that to facilitate that harm reduction in relation to steroid use?
Excellent question. Point one, I'll post the link to the primer in the chat, or I'll send it to you, Calvert, and you can shoot it out alongside this. And there's a whole host of resources on the website that's hosted on High Ground, which is a QuiVAA initiative, which it's the health conversation approach that I spoke about, the results from the trial, so on and so forth. In terms of access, totally agree with health monitoring and health checking. There's been a disconnect between medical professionals and people who use steroids for like 50 years now, partly because I guess as researchers, as health professionals, we said they didn't work, and I can assure you they do. You get very big and very lean, and they're fantastic for that. Unfortunately, that stigma has never ceased to go away, and so generally, when people say I'd like some assistance or some guidance or some health monitoring in terms of my use, the answer is stop, or don't do that, or whatever else. I feel like there is a shift starting to happen, and there's a little bit more receptivity in terms of health workforce and healthcare providers, but I think we have a long way to go. And so, what community often do, and I guess where I'm trying to work a little more closely, is that we have private providers who do blood testing, echocardiograms, and other harm reduction. I guess objective measuring similar to testing steroids that can really enhance, I guess, communities, people in communities, objective markers around what they're doing. So, for example, Hyphen Health offers a program called Roid Safe. You've got there's two others, and I'll list them in the health conversation if you're interested. But often people in community will take those results to coaches, dietitians, steroid educators like Vigorous Steve, clinicians like Dr. Thomas O'Connor, and try and get some interpretation and some direct advice around that. And so this is just another example of, I guess, community-led practices when you're left underserved and I guess quite naked.
Thanks, Tim. And Monica or Ian, do you have anything to add on that front? Covered it all.
Yeah,
we can move on to the next question. And Monica or Ian, if you want to take it as well, please feel free. Jason Ferris asked quite a simple question, I suppose. Given that drug checking or testing services are employed globally, over 30 countries, why don't these services have steroids as part of their checking or testing already? Maybe Ian or Monica, either one of you wants to jump in.
Well,
I think,
I could.
yeah,
Would you
go
like to
for
say?
it.
I was
No,
going to say
because I
from.
think the answer is really in your side in a way, isn't it? The chemistry is tricky, right?
Yeah, I guess it's not just as simple as you collect the sample, you put it into your machine, and then you get your result. There's quite a lot that goes into it. It's what we're trying to do with the actual work is we're actually building a methodology because it's not there yet. Like, so we're actually building a methodology of how the samples are actually tested, and we're slowly introducing more reference material so we can increase that library so we can cater to more people, like to do the analysis. It's like from start to end, it can take anywhere up to, well, from collection, it can take a couple of months. The actual work itself is not long, but the preparation that goes into it is substantial. And then the machines that you're using, they're very specialized, and it's not just Tom, Dick, and Harry off the street that can do the work. Like you need to have trained people and people that know what they're looking at.
And Ian, you can't just use an FTIR, can you? Like is that, and I think this is it. So some of the methods that we can use in drug checking for at least drugs that aren't like super potent, like your MDMA or your cocaine or your ketamine, these drugs, we can essentially find out quite easily with people who are not, they can be trained, but they don't have to be as trained as in the steroid example. But I think there's also, I think what Tim pointed to earlier, that there is this perhaps a blind spot around this, that people are thinking of this as around psychoactive substance use, trying to prevent overdose and overdose related death, which this is different, and sort of, I guess, opening up that box a bit more in terms of different kinds of harms that we can prevent for different kinds of use cases of substances is probably part of the answer too.
Just to jump on that, with some of the material that we're finding, they all kind of stem from the same chemical background, if you like, but it's the functional groups that come off it, which is how these drugs then perform differently in the body. They may be like within like 10 molar masses, but you might have like a half-life that changes anywhere from a day to 15 days. And if someone's going to be using those materials, like how long is it going to stay in their system? What's the toxicity? What's happening to their liver? There's lots of things that we need to be aware of. Like, again, it's about harm reduction, right?
Even just going off of that point, Ian, Matthew Pierce asks around plans to address the peptide market, for example, and you're saying, there's a lot of similarities within the overarching umbrella. Maybe you could speak towards the peptides in maybe their impacts, and maybe Tim or Monica, you could talk about what's being done or how it's being addressed.
From a testing point of view, like what I was saying before is we're actually starting to increase the library. So we've started off with androgynous, like anabolic steroids, but we're increasing it to like your peptides and even like further down the line, like different hormones that might be involved. So from that side of things, there's plans to expand what we're actually doing, but that's what comes down to it with the method building, like, and increasing our library so that we can target more things, which means we can address more samples that are coming in and ideally provide people with more information.
I think just to add to that, we've got human growth and other peptides there that people have submitted. So just looking at analytic techniques for that and what our plan forward is, I guess it's a gap not just for us, but also for private services like Genoshic Analytical, who provide these where, this is something community really wants, but specifically for growth hormone, just because it's so expensive and it's actually so poor quality in Australia. You used to pay $1,000 for a kit and that'll last you maybe a month at a low dose. So you're looking at a house deposit for, a good growth cycle, and you're running it for a year or 2 years. It's you want to know if it's good or not.
And did you have anything as well to add, Monica?
I just wondered whether what you just said, Tim, is the reason why in the different waves there are some samples that were unable to be analysed. Was it because they were expected to be things that you don't yet have the method development?
Yeah, sorry, great point, Mom. So yeah, there was a number of samples that couldn't be analyzed. So some of them were anabolic steroids. So for example, we have only recently acquired the reference material for methanolone and anthate. And so we had that coming through. It's actually one of the most faked compounds on the market, but it's incredibly expensive to get the reference material, and it takes a while. There's others I think that we sort of acquired over time, so filled those gaps, and then the other gaps are the growth hormone peptides, SARMs, so selective androgen receptor modulators, so things like ligandrol and RAD140. We had to get those materials and try and work up a way of doing that. I guess this is all, as Ian said, we have amazing steroid chemists, particularly Ian's committed to, building the program and really making sure that, we have this comprehensive library. So I think slowly plugging all the gaps.
There are so many good questions to choose from. I see that Riley Heron's posted a lot, so I'll try and answer or ask one of yours. I had a similar thought around the stigma of steroids. So there's potentially more of a socially desirable aspect to steroids that they're maybe not present in other substances. I wonder how that plays into continued use, but also into going to a service to test steroids. Would it increase the likelihood that people would access these services, do you think, or would it make it harder?
Throw this one to you, Tim.
So even in trying to get community to submit for the trial, This was tricky, like the amount of messages, like DMs, I got, the amount of phone calls and messages I had to sort of put out there, and word of mouth messaging to go, you know, you're not going to get raided. Cops aren't going to, grab this off you. Like there's some stuff in place there. And the amount of stuff, I guess there were comments on Reddit and other forums there, just basically trying to get at this. And it's really tricky messaging to um like especially outward facing, because in Queensland, I guess where the trial was conducted, steroids are a Schedule 1 substance, so aligning with heroin and methamphetamine in terms of penalty. And so this is a group that, sees the threat of 25 years in prison for getting caught with this stuff. And so it's very, very scary and very, very real. So a lot of that community partnership through QuiVAA, through our steroid advisory group, through word of mouth, through coaches, through athletes, all that work sort of assisted. I get the social desirability thing. I do, because using steroids, you look good, so you're healthy and you're confident and you're powerful or whatever. But I think, unfortunately, that doesn't play out exactly like that in terms of stigma. I think actually this is a more stigmatized group. And unfortunately, they also stigmatize other groups of people who use drugs more. And so other them. I don't know, Monica and I have chatted about this.
Yeah. It's a really common thing though, and you can't really blame people for trying to deflect stigma. I mean, once maybe they're aware of it, perhaps they can see that deflecting stigma by stigmatizing others is, not particularly helpful for the wider community. But we see it a lot, because people are trying to deflect the stigma from themselves by saying, I'm not like them. So that's going to happen. And I guess the fact that so many people in this community are injecting, so that's a major aspect there. Like injecting in and of itself, regardless of what you're injecting, if it's not medically prescribed, has its own stigma. So I think that as well means that this group is still going to be subject to quite a lot of stigma.
Mhm.
Fantastic. I do apologize we couldn't get to all the questions, but
Oh,
you've had some amazing answers there. And if you still have a question that you really want answered, please reach out to the NDUC email and we can pass on your questions to whoever in this panel that you would like to ask. I will now have to end the session, unfortunately, even though I'd love to keep going. Thank you so much, Tim, Monica, and Ian for joining us. Please feel free to turn off your cameras while I talk about next week's webinar. And thank you again for joining us. So for next week's webinar, just waiting. There we go. We have Australia's burgeoning love of medical cannabis with Dr. Lou Mills from the University of Sydney on the 12th of June. Following that, we'll have on the 19th of June, epidemiology and management of invasive infections in people who inject drugs with Dr. Lucy Atwood from the Alfred Health and Monash Health. And also a reminder to please register for the 2025 NDARC Annual Research Symposium, which will be held in Sydney at the Wesley Conference Centre. That is a free event and you can register now. So we hope to see you there. And thank you for joining us for the webinar this week.